Welcome to this episode of eGPlearner, as we're talking about the new GP contract letter, or the proposed contract as it is. Myself and Andy have had a chance to go through it in a lot more detail. We've also watched, I've watched the webinar as well, which we will be talking about, as well as various different content and stuff that is in this letter. What's good about it, what's not good about it, and the key things that you need to know, particularly the bits NHS England did actually miss out and stuff. So let's get cracking as we tech enhance your primary care and learning. Hello, eGPlearners. Welcome to this episode where myself and Andy are going to be looking at the new proposed GP contract letter that we've all heard about over the past couple of days and absolutely breaking it down for you out there in general practice land. But how are we doing there, first of all, Andy?
Yeah, good. So yeah, as people who joined us for the soft spot will be aware, I've just rushed back from the other side of the city. I've been doing extended access this morning, but come back for the webinar. That's the reason why we're slightly later than we might have been as well. And yeah, really excited to hear what you think about the contract. We spoke about it a little bit, but not at length. So yeah, interested to see what comments we might get from people out there in GP land as well. So do feel free to type in your comments into whatever platform you're on, and we'll be able to bring them on screen and give you a little bit of airtime and maybe react to them.
Absolutely. And if you are joining us on YouTube, there is a little poll in there to tell us what you think of the contract, although we'd much rather have your comments and stuff. So, you know, we're already getting some of them coming through. So from Christina, hi, thanks for all doing this on a Saturday afternoon. Sally mentions any chance of subtitles. So normally they are subtitled afterwards because the things we use to do that for us after the event. Unfortunately, I don't know if YouTube will do it live for you. Apologies on that. But we are going to get cracking. And the first thing we are going to talk about in brief is the contract letter itself. So let's bring it on, shall we, Andy? And we're just going to talk. So as usual, these are structured in the kind of summary letter, which is a good starter for the headlines. We'll be going through the detail as well. So you will come away from watching this knowing absolutely everything there is to know about the contract changes. But Andy, I know you like getting in there with our lovely little disclaimer of sorts and stuff, don't you?
Oh yeah, we haven't done this for a while. We're not NHS England. We're not your ICB. We're not your contract managers. So please be careful. This is just for entertainment purposes only. I think officially, information and entertainment. And before you act on anything, obviously use your own common sense and check with people who manage your contract and who you'll be affecting in your area. Disclaimer over, I think.
Yeah, cool. So obviously a lot of this has gone around in terms of the news networks, and you may have been discussing this and stuff. Obviously this letter dropped Wednesday evening, and went to basically everybody involved in general practice. So integrated care boards, primary care leads, which is PCN CDs and stuff, regional directors, etc., etc. And it talks about the contract arrangements that are proposed by NHS England for the coming year. This has not been agreed, I believe, by the GPC, and we're going to talk about some of that stuff in a second. But should we just quickly go through the headline stuff, Andy?
Yeah. It's interesting. Not been agreed, but it says the contract consultation has now concluded, and I'm writing to inform you of the final arrangements for the upcoming financial year. So certainly the authors of the letter feel that that case is closed. So I guess we'll be dipping in and out, I think, because we've decided to kind of structure it in a slightly different way in terms of how we go through it. But the letter, obviously, there's a brief introduction. It outlines the different areas, and it sort of cuts it in terms of what they're trying to address in terms of a summary, and then what they're trying to achieve with the contract. So cut bureaucracy for practices, help practices with cash flow, and increase flexibility in terms of how funding's used, give primary care networks more flexibility, support primary care networks to improve outcomes, and improve patient experience of access. Those are what they what they're stating as the main aims of the contract. And then it sort of breaks it down in terms of how they will be, well, some headline things about pay, how they will be cutting bureaucracy, how they'll be helping practice with cash flow, how they'll give PCNs more staffing flexibility, streamlining the PCN DES, improving patient experience of access, and then talks about what will happen next. And and there's a number of appendices which we've had a look at as well and done some maths around, and they're quite interesting too. So, but Gandhi, do you want to lead us off in terms of how we will be?
Yes. So we're obviously going to go through all those different sections. We're going to focus on the financial stuff, which is particularly the uplift, the QOF changes, IAF and CAIP funding changes. Then we're going to talk about the PCN DES changes outside of those, including the ARRS roles, as well as then some of the stuff that NHS England haven't talked about in detail at all. And then finally, there's some extra things that they put in there, and particularly miscellaneous stuff that we'll talk about that is very important to be aware of, but probably less directly relevant at the outset and stuff. However, before we do that, one of the interesting things that was listed in this letter is that they said that they were going to do a webinar on the 29th of February, once every 4 years, as I guess. But let's be honest, NHS England are pretty decent with getting their webinars sorted. And this time was interesting. So I know Andy wasn't there. I was sort of, so I tried something for the eGP learners.
I've heard it was a bit controversial. You tried something new. So, Gandhi, what happened? How did it go down?
Well, first of all, if you do end up watching that episode, which the links that will be down below, is basically me watching the webinar and commenting it at the same time. Frustratingly, you can't hear the audio of the webinar. Maybe that was a good thing. I don't know, because it is meant to be a watch-a-thon.
Anyway. I was wondering if they'd, if they'd come after you for it, Gandhi. But I think probably
if they decide to, I can confirm that I checked beforehand. There is no restriction on broadcasting the NHS England webinar whatsoever when you sign up to it.
That's good. I'll stand down the eGP Learning legal team. They can stand down for the weekend.
And just to be clear, I didn't show any of the comments, which I know is the spicy bit, shall we say, which we're going to get to in a second. But I think before we get to that, one thing I will comment, I think it was well structured. So Amanda Doyle taking the lead, going through the document, she went through most of the stuff. And like I said, there is one thing I think she missed out on, but whether that was just because it was a bit chaotic and stuff towards the end. But did go through various points, very clear direction that this was the financial envelope they were given by the Department of Health to NHS England, and they have done the best that they feel they can do with the financial envelope that the Department of Health have given NHS England. So that came through multiple times. Thoughts on that, Andy?
Yeah, I mean, I wasn't there. It sounds like she did a good job. That was one thing that struck me about the contract in general, really, was that they haven't really increased the financial envelope at all in terms of core general practice funding or in terms of PCN DES funding, which I think is the main controversial thing about it. If you actually look at some of the individual actions within it, a lot of them do make sense in terms of reducing administration and increasing flexibility in terms of how funding's used. So I think that's a fair reflection of the reality. And they're in a difficult spot, aren't they? I guess, and we don't see how hard they might fight internally for increases in budget. I know it's quite difficult to get the Treasury to release money, so and all departments want that. So I can appreciate it was probably quite difficult.
I guess we've had some comments. Dave jumping in with spicy comments, quite understated. And then Seaside, Sarah, definitely the busiest and angriest chat section I've seen in a long while. I guess what that takes reference to is the comments, which, like I said, I didn't show. But it was clearly evident that there was
what were people really angry about or most angry about, Gandhi?
So many people, I think there was some direct attacks, which I don't think were appropriate in that sense, but very much that many people felt left down by the contract offer, that there's obviously no significant increase. Talks around why it was 2% and definitely not agreeing that 2% was the right level. There was one interesting one where somebody basically stated that because of the information they've now produced, that person was now retiring. And leaving general practice, basically. So fairly emotional, fairly controversial in that sense. It was also very numerous. I think they counted over 600 comments, which is significant. I mean, there's over 1,200 people. So kudos to NHS England for actually recognizing this would be popular and, increasing the bandwidth. So they did turn it to a webinar version rather than their normal version, which obviously would have limited the number of people that could attend. It's kind of one of the reasons why I did the watch-a-thon, because I anticipated they probably hit the max capacity, but actually they anticipated that. So that was at least a positive thing from that point of view. But yeah, interesting to see.
Interesting.
Sorry.
So I was interested. I was just reading the comments actually. So Stephen Taylor's. So it's interesting. Yeah, just identifying the man at the Treasury, or at least at the Chancellor is Jeremy Hunt, who has actually made the case for increases in GP spending multiple times, and also for continuity, in the form of the named GP sort of policy that he had as well, and difficult backroom haggling. So where are we going next? Gandhi?
So next we're going to actually talk about the key change that they've talked about. So the big one is obviously the 2% uplift. So probably worth we go down to the annex now, which is where the detail is. As ever, we keep telling to people, when you get these letters, the devil is always in the detail. We don't have all the detail, but we have a good chunk of it. In particular, they have broken down why they came up with the 2% number in terms of the uplift and stuff. And basically, it's more than 1.9%, which was originally perpetuated, but it's still not a significant amount more.
Yeah.
Yeah.
Taking the headline figures, I made that to be an increase of 2.23%, actually. Although I believe the maths is very, very complicated. But just to, 259, taking it up to 11,864. But nonetheless, in an environment where we've had 6% increase in doctors and often paid to other members of staff like practice nurses last year, and the minimum wage going up by sort of 10%, the core costs are far outstripping those sorts of increases, which I imagine is what everybody is thinking in reaction to that figure.
And I think that it's important to remember that obviously repeatedly we've heard from both NHS England and the government that the general practice is under a 5-year contract, which is why there was no increase to any of the significant amounts of funding that general practice had over the past 5 years, apart from the COVID streams, because of that reason that we were under a 5-year contract. However, obviously various other parts of the system have had significant increases in percentage-based pay. And as a result of that, general practice's share of the NHS pot has actually reduced over the past few years because of that variance. So the recognition that now that we're in a more difficult financial situation, that as a result of that, general practice again is being made to suffer, clearly was, I think, one of the reasons why many people were quite vehement in their comments and that kind of stuff. If this was a year ago, if this had happened a year ago, actually, I think we'd been in a completely different situation. Because actually then there was obviously potential funding available. There was less of the inflationary issues, even though there was still inflationary issues and stuff at that point. But I think, we're in the situation we're in. They did put this slight caveat that they will consider the response to the DDRB changes, and this time it will apply to GP partners, which obviously previously it hasn't done, because every single time they've repeatedly said that GP contract has been negotiated for 5 years. But obviously the key word in there is that they will consider the response of the DDRB. They will not abide it. And I guess there's also that question that many people feel the DDRB are not necessarily an independent organization.
Yeah, they produced a really interesting report, and I think later in the year we will be looking at that report. I've had a look at it in the past, and it's really long, full of charts, and they really do try and evidence, why they're making their suggestions. It feels a little bit like they're trying to separate the issue of GP pay from funding to general practice, and that there's an attempt to sort of separate those issues in a way that that might make this contract easier to swallow, in terms of kicking
maybe
that down a little bit. I don't think it really will, but I think that might have been some of the thoughts behind it. And also, I think under normal circumstances, outside of multi-year contract kind of settlements, normally pay increases are the remit of the DDRB. I think so. In some ways, it could be seen as a return to normality. Nonetheless, I think the headline is that 2% does not feel like enough in the current environment, and that's what everybody is most upset about, I think.
Absolutely. I guess it does raise the question of, again, they repeatedly said this is the financial envelope they've been given. That's not going to change. What options are there after that? We will come to that towards the end. But I guess key points I noted was point C, which was 1.6.8% inflation in line with the government's November 2023 GDP deflator. It's like they've deliberately picked possibly the lowest increase in inflation when obviously every other marker is considerably higher. It just doesn't feel right, does it, Andy?
Yes. And I guess maybe it's a good point to say that the BMA are also not happy about this contract, and they're putting out they continue to put out messaging around their referendum, which will be running 7th to 27th of March, encouraging people to become BMA members so that they can be polled and they can sort of most fully represent as much of the general practice profession as possible, so that when they go to contest this, they have a mandate. They have the views of enough people and the support of enough people to have their views heard.
Yep. And I think important to remember that only BMA members will be able to vote in that. So if you're not a member, unfortunately, you won't be able to have a say in what happens. And I guess that's why they're keen to see people sign up and stuff. But yeah, I guess just before we move on to the next kind of financial stuff and things, probably worth taking some of the comments that we've had. So Mike Neville coming in, no justification on trust receiving 650 million bailout for trusts on costs, and the uplift in general practice fund envelope is only 40% of that figure. Yeah. Interestingly, general practice doesn't go in the red. It can't do, because when it does, the practices close, unlike trusts, which when they go in the red, they just seem to get bailouts and handouts and stuff to help keep them running and stuff.
To most often, general practice is bailed out, but it's bailed out by GP partners, taking a cut in their income. I see that very often in colleagues.
Yep. And Steve Taylor, excellent number of comments and graphics and various other stuff. But most important figure is pay, not payment per patient, which is £35 less in real terms since 2016 and stuff. So significant. Tabula Master coming in, a great name there. Partners will be handing back their contracts. Many of us have had enough. I'm not going to deny many people probably feeling that way at this point in time. And Sakib mentioning the DDRB has, Department of Health has ignored DDRB recommendations when it suited them. Yeah, so I guess that's the key thing that we're concerned about in some ways and stuff and things from there. Nat clearly identifying the biggest risk with all of this, though. The minimum wage rise is the biggest killer of all. The contract uplift should be covering that. So for those who aren't aware, which I don't know how you could not be if you're not involved in general practice, in April, obviously the minimum wage goes up, given the fact a lot of our reception-based staff and things are on those levels. That's going to be a significant rise for general practice in terms of outlay. And obviously we're not seeing the same level of increase in our income, and we can't charge patients for coming to us. So therefore, actually, unlike every other business, that's where the problem comes into play.
Yes. And I think, staffing levels, capacity, access, standards of service may drop in response to the.
I think that's one of the recognitions that people have to have with some of this. But we're going to crack on and talk about other changes. So when we're still talking about finance, the big other one that is definitely being pushed across is the QOF changes. So one of the key things that they did mention on the webinar is that some of these changes they've had to be a little bit more limited with, because there is currently the incentive survey going around about trying to find out information about how to change incentive-based payments for lack of better terms, that's QOF and IIF currently in general practice. Because of that, they felt there were some changes they wanted to make that they couldn't make until that process had finished. Now, we know this is probably going to change next year in terms of the contract because of that survey information. But these are the changes that they have made in the interim, which is basically they've cut out a load of QOF points in particular, and they are going to income protect those based off 2023 data. So everyone has basically a month to figure out what their income protection levels are going to be based off that information, because what you get at the end of 2023's financial year will be what you get for the next financial year as well. Is that right, Andy?
It is, yeah. Well, that's how I interpret this. And I did some quick calculations, based on the standard value of a QOF point, which I think is about £214 for the national average list size practice, which is just under £10,000. The 212 protected points equates to about £45,000 for that typical national average practice, of a total QOF value of £180,000 for all of the 635. So just to give people an idea in terms of how much money is being protected.
Yeah,
quite a lot, but not an enormous amount.
Yep. I guess the ones that are being protected are the big ones are the registers themselves are being income protected. That's one of the biggest points. So 81 points for those. Also, QOF QI is going to be protected, so that there probably is not going to be a QOF QI project as such, but we will talk about why that probably is when we get down to the CAIP funding. And then some of the other registers are being protected as well as the cancer care indicators as well, and a couple of the minor ones from different areas like mental health and depression in terms of what they look at. They're not minor health issues, absolutely, but it's just what they monitor in terms of being looked at. So in total, 32 indicators are going to be income protected. And as a result of that, that will be hopefully provide some support. The other change, which is quite interesting, is the aspiration payments the level is going to go up. So from 70% to 80%. Do you want to explain that to everybody, Andy?
Yeah. So So in terms of payment for QOF, you receive it in, I believe two chunks in terms of how it comes in. So you get your aspiration payment. So based on previous performance, they predict what you're likely to achieve in QOF, and you get that upfront, so to pay you for doing the work for next year. And then there is a final settlement payment. What do they call that? A payment that basically brings you up to your actual achievement. So a correction payment at the end
It's
of
your
the year.
achievement payment, isn't it?
Achievement payment. That's it. So essentially, you will get more of that chunk up front, then you'll get less in terms of the achievement payment. And I guess there's the risk or possibility that if you achieve less than 80% QOF improvement, that might even represent a clawback. Nonetheless, I guess they're trying to improve practice cash flow with this measure. I think it's nice. I don't know quite how much difference it makes in terms of over the course of a whole year. You're still getting the same amount of money. I don't know. Do you think this will be helpful? Depends how much cash you've got in your business to keep it going, or how close to going bust you are. This could keep you going, I suppose, if you're really on the red line in terms of your finances. What were your thoughts, Gandhi?
I guess there's a couple of things to think about. So one, with the register being protected, I raised the question of whether or not that means you can change your prevalence data, which obviously prevalence data has an impact on the number of value of your QOF points and stuff. I guess additionally with that, it's this whole concept, like you say, of the potential risk for clawback. So if you achieve about 80% of your QOF points, actually, you potentially now run the risk of having a clawback, a greater risk of a clawback as a result of that. So then you may need to keep some of those funds aside. I think it's beneficial in terms of they've changed the easy stuff. Let's be clear on that. I think the challenge many people would probably look at this is that obviously the challenging QOF, the real box ticking QOF kind of parts of it and stuff hasn't really been looked at in some ways. And also for those areas of deprivation, which often do badly on things like cancer screening and immunization based QOF and things, they haven't been looked at either, which is unfortunate because that's the part that's most time intensive and not recognized about the variation that happens across practices as well. So none of this does anything to help with health inequalities in my view. But yeah. And I think people are joining us in that. So Seaside Sarah coming in with the talk about cutting QOF bureaucracy, and they cut the least bureaucratic indicators and things. So yeah, interesting comments coming through. The last QOF change, which was quite, from my point of view, was quite interesting actually, was the COL2 QOF indicator. So this has been slightly controversial because of the fact the QOF indicator for cholesterol 2 is higher than the NICE guidance of what they recommended you should be achieving. They are going to align themselves to that for the next financial year, but I argue why they shouldn't have done that already and done a mid-year change. I mean, they make so many changes about the documentation of QOF and the codes and stuff, which is part of the reason why we spend half our time redoing all the work, which is where the inefficiencies come in. And actually, they could have solved a lot of that for practice this year, but they've intentionally decided not to. And I wonder if it's because they know they'll have to pay more money because they've made an error in the first place. But hey, that's why they probably did it.
Yeah, the cold maths might come down. It might come down to the cold maths, Gandhi. So,
yeah,
but nonetheless, it's a welcome change.
So that's QOF. We're now going to jump around the letter a little bit. So if you are joining us on the letter, I'm afraid we are going to jump a shift. We're going to go to the IAF changes. So they're a little bit further down. The reason why we've done this is we're trying to stick to finance-based stuff. And the IAF changes are interesting. So many of you probably remember last financial year, they got rid of a lot of the IAF criteria and only left us with 5 or 6, I think it was, wasn't it?
5, it was 36 down to 5.
Yeah.
So quite a welcome reduction, actually, because people were focusing on COVID recovery and things, if we think back to this time last year.
And this year, they're cutting them down even further. So we're only going to be left with 2 IAF indicators, which will be the learning disability reviews and the cancer screening based ones, which is around the fit testing. So they did talk about this. So they talked about the fact that the learning disability reviews obviously offer really powerful quality of care for those patients with significant need. And also the reason why they kept the fit one is that the wait times for lower GI cancer are the only wait times that have actually dropped. And they are attributing that drop to the fact that this is being done to some degree. So that's the reason why they kept those 2. It does mean that they have reconciled some of the other indicators, particularly the immunization based ones and the other. There was another screening one, wasn't there, Andy? I think, if I remember rightly. Forgotten what the other three were now, actually.
I'm not sure. I was going to look it up, but I was
It was
busy.
immunization based. It was flu immunizations and other kind of things, which in that sense is something that I know I've been shouting for ages, because actually IAF was really, what's the word? It begins with P. Sorry, everybody. I'm having
Proactive, progressive,
penalizing.
penalizing. Okay, the opposite.
Penalizing. It's to those networks with health inequality challenges, because actually they're the areas where it was really hard
The
to achieve them.
achievement was really tough.
Yeah, exactly. So I think the fact that they have reconciled those is a positive step, because from a health inequalities point, this part I think does address some of those inequalities. But they're the main changes they made to IAF, and the reason why they've done this is because they've put that reconciled income into the CAIP funding. So we're going to talk about that in a second, but just before we do, Andy, what are your thoughts?
Yeah, I was going to say, just in terms of appreciating kind of the value and the sums of money here, because they don't talk about that within the contract. So for a typical sized network, an IIF point is worth about £198. So if you actually, so there's 5 to 2 sections, but there's actually 262 remaining IIF points. So that equates to about 51,000 in terms of those remaining. Hang on, right. So the total value of all the ones that were remaining, I think, was about £51,000. I've done my maths. I'm looking at it at the side of the screen here. There are about 58 points remaining in those two sections, in the fit test and the learning disabilities, which is 58. So there are £11,500 remaining in terms of achievable IF points, and about £40,000 is moving into the capacity and access payment.
And so that's the part we're going to talk about next. So the capacity and access investment payment and stuff. So many of you are probably aware right now at the moment, networks currently get a chunk of funding. So for you basically doing what is now termed modern general practice access and recovery. And as a result of that, they're going to continue that model for the next financial year, because this was meant to be a 2-year phasing prospect. The payment structure is still going to be the same. So 70% of that payment will be made directly. There's no work needed to be done for that. Obviously, the amount is going to increase as a result of this phasing of including the CAIP funding into the pot. The reconciled IAF funding into the CAIP funding. But the other interesting change is that the 30% payment that many networks currently won't have and won't get for another couple of months, because the ending point is not till May, that will now be given in year if you have achieved the 3 main criteria of the CAIP funding plans of the modern general practice access and stuff. So we are going to talk a little bit about that now. Probably the best way to go, Andy, is the lovely table that talks about the stuff. Yeah, so that's the one.
Achievement.
So that's the achievement. So effectively, you have to have better digital telephony, which is basically signing up to the cloud-based telephony platforms based on BPF. So I know there are some practices that have decided not to do this. So this will therefore mean that they won't potentially have access for their network to the payments for CAIP funding, which are now going to go
they may
up.
now have to choose to do it, but have missed out on financial support for doing so because of a lack of information and the contract coming late, which is quite sad.
And I can understand why some practices decided that. There absolutely has been an increase in monthly costs that's been associated with going to cloud-based telephony for some practices as a result of it. And clearly that was the reason that I think they felt they couldn't do that. I know there's been some practices just been caught by situations where they've not been allowed to go for it as well, which is really awful in my view. But the requirement for that is, and this is what comes through repeatedly, both on this and in the webinar, the reason they're doing this is because the cloud-based telephony systems that are on the BPF allow them to have the data to understand what's going on in general practice. And in the letter, it lists the 8 different data points that you have to report on.
I think it's worth looking at that, if not now. In fact, I'll see if I can find it, Gandhi, because
so it's on page 7, at the bottom of page 7.
Because I think it's interesting because there's a number of things, including vaccinations, where practices will have to agree to release more data to NHS England, ICB, and of course this will be used to understand demand, put funding where it should be based on demand. But you do wonder if there's an element of Big Brother watching and contract management, that can be that this data can be used for as well, and potentially will be. So you're looking at sharing information around call volumes, abandoned calls, time to answer calls, missed calls, wait time before abandoned, callbacks requested, callbacks made, and the average length of call times. So there's quite a lot of data going up to NHS, not just the ICBs, not just the primary care networks, but NHS England as well.
Yeah.
Be interesting to see how they choose to use that.
And I think, like you say, this is probably information they want to determine how they move forward with the future contract. What's interesting, though, is that call data is going to change over the year because of the other two parts of this, which is, number one, simpler online requests. So absolutely, online consultation is going to be part of the contract. And for those practices who have decided not to engage with online consultations, actually there needs to be some parts of that within your practice structure in order to continue receiving the CAIP funding, which is the significant chunk of the PCN funding that practices can have.
Gandhi, another thing I noticed with the contract was that in order for this 30% to be released, all practices within a primary care network must offer this. So in order for the funding to be released to any practice in a primary care network, all practices need to do this. So it may be harder locally to actually just think we don't want the CAIP money, let's opt out of this, dig our heels in for a little bit longer, because you have the pressure of all your neighbours who perhaps do want the CAIP funding. So I just thought that was quite interesting, that it's an all or nothing in terms of primary care networks and the 30%.
Sorry, Andy, I temporarily disconnected my headphones. I didn't hear what you said.
Yeah, I was saying it's all or nothing. It's all practices or no practices achieving these criteria and allowing the drawdown of that 30% funding from the ICB. Or the
I'm going to come to why that's going to be important in a little bit later as well. Anyway. But similarly with the telephony, it's exactly the same thing with online consultation stuff. But also there's also faster navigation and assessment response, which is about care navigation within your practice and things. I guess key thing to point out, this doesn't state that you have to do total triage. There is a difference between total triage and simpler online requests. So I guess that's the key thing to bear in mind. There is a difference there, but we'll come to why Andy's point about all the practices being involved in this is going to be really important in a second. I think just before we do that, again, probably worth taking some of the comments and stuff. So the one I'm going to bring on is, again, Seaside Sarah. If practices have a CBT system which doesn't include all 8 of those options, will they be forced to add that on or end a contract early to switch to a framework supplier? Simple answer is only the framework suppliers have been approved to provide all of those things. So if you have a provider that doesn't do that, you won't get the CAIP funding. Simple as that. So yes, you will either have to buy it as a bolt-on, but more likely you will have to switch to a framework provider.
Yeah.
Yep. If you want to have a look,
it's unlikely they'll be able to help you, but you never know. It's worth a conversation.
I think if you want help with that, obviously I did a comparison webinar of some of the providers a short while back. That's on the eGPlearning channel. So feel free to have a look at it. And I will put the link to that in the show notes to this at the end and stuff if you want to have a look at that. But there is some really interesting providers out there that are doing some cool stuff and things as well. Nat commenting, I don't like at least for the duration of core hours. I'm not quite sure what that means.
Must be on the screen at the moment. I'm not quite sure. Maybe we'll have to come back to that.
Yeah, Nat, if you could just expand on that, that'd be appreciative, just so we can figure out what that part that's making reference to. I guess the reason why some of this is relevant that we talked about, so there's 2 parts about this. One, which is listed on this page, which is in order to get the 30%, the PCN clinical director will need to give assurance to the ICB that the practices have done this. Once they've given that assurance that the practices have achieved this, that's when the 30% can be released. So in year, unlike the current 30%, which is going to be released in the following financial year. So it will be the PCN clinical director's responsibility to give that assurance and to make sure it's happened in order for that funding to happen. Does that make sense, Andy?
It does. Yes, that makes perfect sense. It's a lot of responsibility, isn't it, to know? So people, PCN directors have to think about what their process and system for being confident to make that assurance.
And I guess that leads into the PCN DES changes that have come through. So the reason why this is important to recognise is that there are a few changes that they have mandated in part of the contract changes. So number one, is they said that the PCN clinical director job will change. So apparently, Andy, my job spec has just changed, or will do in a month's time. In terms of
How did the consultation go about that with you, Gandhi?
it's a great consultation, you know. It just basically came as a letter.
That's fine. So the current definition, I mean, that it was never really well defined, right, in the original
True.
PCN DES, and so people sort of locally decided, I guess, what that meant. In some ways, I guess it's providing some clarity. And what do you think of the description, Gandhi? I mean, are you happy to do that job?
I mean, to be honest, the description is pretty much what I thought I was doing anyway. However, the key points it does focus, and this part wasn't particularly mentioned beforehand, is supporting transformation towards modern general practice and supporting the PCN role in developing integrated neighbourhood teams. So that's the part I think that is been specified more clearly to me, which wasn't really necessarily a direct line of the job description beforehand. We kind of did it anyway because we knew we had to do it, and doing the modern general practice access was more about coordinating the funding, but it specifically gives the responsibility of making sure modern general practice is acted on in your network footprint, which, as we saw, well, the reason is because you have to give assurance it's been done in order to get the money.
I think it's quite a big change, actually. And the whole modern general practice thing really came out of last year's contract imposition. So the changes to the core contract that were imposed via the statutory instrument by the Secretary of State for Health, without the involvement of the GPC. So in some ways, those changes were quite controversial when they came through. And
Very
now,
much so, yeah.
Without consultation, your job description has been changed such that you have to support those. That's could be considered quite a big deal.
It'll also be interesting to see whether or not this changes HMRC's view of the job as well, because there has been some question around how PCN clinical directors should be paid, whether it's an employed role, etc., and how that works in terms of taxing and stuff. Will this give a bit more clarity? I'd be keen to know what the accountants think of that particular direction in terms of the job description, because like you mentioned, we've now kind of got a formal job description of what the role is for all networks rather than individual networks being slightly different. Interesting to know what that means. Lastly, when it comes to PCN DES changes, so in particular, they have decided that the specifications for the enhanced services are now all going to be reconciled into an overarching specification. So that's things like your care home LES one, the cardiovascular enhanced service, anticipatory care, personalized care, all those kind of things are now going to be, they're all going to be rolled into one big overarching enhanced service. The exception to that being in the enhanced access service, which they're going to continue in its current format. Again, no increase in funding, but it's going to continue. And the answer for that, the reason for that is simply they feel it's just not been running long enough to evaluate if it's had a benefit or not. So that's why they don't want to change that.
Yeah. Candy, I think these sections, whilst very light in detail, and the detail will have to come in the future, and presumably it's on its way, they are significant in a way because we knew that the ARRS funding was continuing. I think there was still a bit of a question mark hanging over the rest of the PCN DES funding and assumptions that it would continue because it's needed to support the ARRS, workforce in terms of administration. But I think this is giving us the signal that kind of all of it is likely to continue, which we might have been expecting, but I think it confirms that. Again, I was going to ask you what you thought about the changes to the PCN clinical director payment, because I thought this kind of snuck in but was interesting. And I'm no longer a clinical director. It doesn't affect me directly. But up to this point, the clinical director funding has been identified as a separate funding line for primary care networks. And that's meant that in some ways, that commitment in terms of hours and time and that you'll actually get paid for that level of hours and time at least has been protected. And now they're pooling together the clinical director payment along with the L&M, the leadership and management funding, and the core funding, all together to give you a flexible pot. So that I wondered, so what you think about that really, because I can see some clinical directors thinking, oh, I could do with more time. Some primary care network practices might think the clinical director doesn't do very much. They need less time, and it could make for some difficult conversations given that it's no longer a protected pot. Flexible, good because it can expand, but also at risk maybe because someone could take that away and decide that you want to have another manager and have less of a clinical director or not have a deputy clinical director. Thoughts?
Well, exactly what you mentioned. I think every network's going to look at this thinking, what is the best situation for our network? So I think for those clinical directors where they are doing more work than they are being paid to do, they could look at this and say, actually, I can now have an increase in pay commensurate to the amount of work I'm doing. Vice versa, the practices within those networks may look at this and think, actually, our PCN clinical director does nothing, and actually, we don't think you should be paid anywhere near what you were, and we want to change that and stuff. I think for me, I would hope the flexibility is a positive thing, because at least it means that you can then direct that funding to getting the resources you need to run your network more effectively. And you've got more discretionary control over how that runs. I would always hope that as well, how that's done is collaboratively with your practices, but I appreciate not every network is in a situation, hopefully like mine continues to be, which is, collaborative practices with supportive practices, and myself and my co-clinical director working as hard as we can to make sure they function as best as they can and things. But yeah, you're right. The variation, I think, is going to have some impact.
How about if they said we've got 6 practices, everyone could have 1/6 of the clinical director funding, and let's have 6 clinical directors.
Well, it'd be interesting to see how that works.
Chaos, wouldn't it?
Yeah, it would be absolute chaos. But then also, who signs off the document then, if that was the case, in terms of you got your CAIP on there?
Look back at those
They'll have to vote.
that were done in 2019. Anyway, let's carry on.
So that's all the stuff in terms of changes with the PCN DES. However, the part we haven't talked about, which is probably the other part of the PCN DES, which Andy alluded to, is the ARRS roles and the flexibility changes around the ARRS roles. Now, this was interesting. So a couple of changes that have come through from this. The big one being that they have now included another additional role into the ARRS mix, which is an enhanced practice nurse. Now, Andy, do you know what an enhanced practice nurse is?
No, I've not seen it properly defined anywhere. My guess, Gandhi, would be that it's a nurse that does something that's different to normal practice nurse stuff. I guess, because there's always been this position of additionality in terms of the additional roles reimbursement scheme, and a bit of worry that funding might be used to support existing activity, which is why they've always been very strict to try and make sure that everything is additional. So, I don't know. Do you have any clearer idea? Go for it.
Interestingly, I do. So, which I asked the question. So, effectively, you've got your practice nurse here. Okay. You've got advanced practice nurses here. So these are nurses who have done some additional qualifications and training, typically master's level, etc., whereby as a result of that, they can now do things beyond the scope of a traditional practice nurse. And classically, that ends up being things like, for example, significant minor illness, specific case, working completely independently, prescribing, etc. An enhanced nurse is in the middle. And what that specifically means, it's a practice nurse with a particular area of focus that's specific and manageable by that individual. So you could argue a learning disabilities practice nurse would fit the criteria of an enhanced practice nurse. A frailty
what about my nurse that commences insulin and
well, specialist area whereby you could argue again that is an enhanced practice nurse, because that's not normal practice nurse's job. Not every practice nurse would do that. So therefore, she's got a specific and a specialist knowledge area that she's functioning above what she would normally do as a practice
expanding
nurse.
That function would be good for the population in our area, actually. So I can begin to see how this makes sense, in terms of primary care network funding, and it's an increased flexibility, isn't it?
Which
I think is welcome. I've just seen a fantastic, very playful comment. I'm just going to bring on from Steve. Is a GP an advanced practice?
So this was commented in the webinar. No, and this was commented in the webinar, and I guess this is one of the key things, because obviously this was one of the requirements the GPC had with the negotiations, that the general practitioners were added to the ARRS reimbursement scheme under an enhanced model as well, so to support the additionality. So it wasn't just GPs had access to the funding, it was GPs doing specific roles as an, so for example, a frailty GP, a safeguarding GP, etc., would be added. Amanda Doyle did comment specifically, GPs are not additional roles, so that's why they can't have the additional role reimbursement scheme. That was the specific requirement and things. So it was commented on in the webinar. You mentioned the flexibilities as well. So that's the other thing that has changed. All the previous criteria and restrictions on the additional roles is pretty much gone. So you can effectively, within the budget concessions you've got, have whatever role you need That also includes the mental health nurses. There's no longer a requirement to 50-50 share with your local mental health team, trust and stuff. The only one that is now limited is the enhanced practice nurse, which is currently 1 per network, or 2 if you're greater than 100,000 patients and stuff.
Yeah, I just picked up on this line here, which I thought was interesting. The PCNs will be able to recruit other direct patient care, non-nurse, non-doctor MDT roles if agreed with their ICB. So it's practically anything, right? As long as it's not a doctor and it's not a normal nurse. So that's quite a high degree of freedom, really.
And they've also included some of the trainee roles for SPLWs as well. So trying to, I think, encourage more people going into the transition for the training part of that to support them into the roles and things. So they have significantly changed the flexibilities of the ARRS funding. The really, really annoying thing that comes into this is because there's not been actually an increase in the level of funding that networks can use, and because of the push for many networks to maximize their funding in this financial year, actually, most networks aren't going to be able to change a lot of this in the short term, at the very least, unless they suddenly make people redundant or repurpose half of their roles into something else, so then they can actually take advantage of this, unless they happen to have an underspend, which actually most networks probably don't.
There's always that nasty term, natural wastage, isn't there? You know, people do leave and come out of roles, which might liberate funding over time. And sometimes organizations do restructure due to changes in the operating environment, contracting environment, you know, and the needs of the business. So you could see some primary care networks entering into restructuring that results in roles being made redundant potentially, which, having just had a push to recruit everybody, would be a real shame and quite chaotic. But
as ever, if they'd made these changes earlier on, I think we would have seen a considerably different engagement with the PCN DES, but also I think we would have seen much more stabler general practice and PCNs as a result of it. The fact that they keep changing this every few months is really frustrating. And I happily say that as a PCN clinical director. I'm now left thinking I can't do anything with this because we've already maximized our budget. The only way for me to do is to get rid of people, and I don't want to do that because we've invested time, effort, resources, engagement, all the stuff a PCN clinical director is meant to be doing. Just fix it. And anyway,
Gandhi, the only other thing in this section that I thought was interesting, and you may have picked up on it as well, is that the mechanism by which commissioners redistribute unclaimed additional roles reimbursement scheme monies between, so across to different PCNs, will be removed. So for me, that means at an end of that, the other primary care networks, you know, underspent. We have underspent money. You can bid for other people's underspent money. It seems that option, that level, that flexibility at ICB level will be removed. I sometimes felt that sometimes perhaps controversially might have involved redistribution from PCNs in areas facing deprivation and high inequality, who perhaps weren't quite as well placed to take full advantage of the DES, you know, to other areas who were really, you know, on the ball, potentially in more well-to-do areas. I thought that might represent a bit of regressive redistribution. So that won't happen anymore, but it's interesting. And it might also reduce the overall cost because you can't redistribute underspend. So those underspends would just remain unspent. So it may reduce the cost a little bit over the country as well.
But I guess that's an interesting point to mention. So Nat comes up with a comment. I don't understand how practices have had enough ARRS money left to worry about needing it to include GPs. We're spent up and I couldn't get rid of the roles we're paying through via ARRS. PCN concept doesn't work for itself, doesn't work for us. Geographical basis isn't helpful. I think, you know, some of that speaks to me on the concept that, you know, like you mentioned, Andy, some areas just haven't been able to recruit, so there is an underspend. However, most areas, I think, have tried to maximize the spend as best as they can for the benefit of their areas to make sure they get as much use out of it and things. So therefore, you know, that makes it more challenging, doesn't it? I'm going to take some more comments, I think, because we've had some really good ones and
got
things.
Lots of comments.
Yeah, we're definitely. So CAIP has come in. I think that the ARRS term should be renamed to accommodate GPs. Well, it's the term. Let's be honest, they're not going to change it for that probably intentional reason and stuff. Mike Neville, why a nurse with a specialist area of interest but not a gypsy? Again, I think that's what the GPC were pushing for, but obviously they felt that would not be valid and appropriate for them to do so for whatever reason.
It's interesting, Gandhi. Why do you think they've held the NHS England have held the line on this? Because it does feel obvious, you know, that there's not money there. You know, there isn't money in the pot to increase core funding. to pay for GPs, which is sort of what the public are crying out, for essentially, as well as the other useful roles. They could have made that change. Why do you think they haven't? To get inside their head a little.
I think if the cynical part of me would probably say NHS England is a bureaucratic organisation, the bureaucracy of just renaming a scheme to allow GPs to be in it. They probably just said it's additional, so we're not having GPs. That's probably my view.
It feels like a way of solving some problems over time, and saying actually now there is more funding available for GPs. We've listened. Potentially, I'm sure they have their reasons. Otherwise,
and again, whether that's an NHS England viewpoint, whether that's a Department of Health viewpoint, I lumber them both in together. To be honest, a perceptional viewpoint that they just don't want GPs in the additional roles.
Maybe next year we'll see enhanced GP roles in there,
maybe
potentially.
At which point there'll be no funding to do it with anyway. So who knows? Let's have a look. So Seaside Sarah again. If not a GP additional, then surely the same would be true for an EPN and some other roles. Very valid point. The EPNs, enhanced practice nurses. How is that different from an enhanced GP? But obviously, there
it might be in the application. It might. We may be required to get ICB approval for these enhanced roles to make sure they are additional.
Well, the additionality clause is definitely there. I think that's the big concern. It's the whole additionality aspect of it and stuff. And also Sarah mentioning that, as usual, making it difficult to plan long-term or even medium-term as a PCN. Absolutely agree on that and stuff and things. Sakib asking the question, is the funding for 24-25 contingent on how much ARRS funding is utilised at the end of March 24? Yes, sort of. Unfortunately, I think that's already been agreed based off your submissions based in October 23 was my understanding, and based off your plans at that point. But what you have is what you will have moving forward, and you won't get any more. Sarah McHale commenting, it makes no sense to exclude gypsies, and now PCNs and practice can employ doctors working for hospital trusts. See change to performers list unless you would want to include GPs. So Sarah's kind of gone on to the next section, which is what we were going to talk about. Which is the performers list changes. Now, I will be clear. This was the point that the NHS England webinar did not touch on whatsoever. So it's 14, 15, 16, 17, Andy.
Okay.
It's a little bit higher.
I had a look at this. You tipped me off to this, Gandhi. So, but I see where you're going. So,
okay. So, and this is our interpretation of it. So, please note that we may not have read this correctly, but we think we have. So they've put this part in about the performers list changes. So mentioning about during COVID, obviously there were some minor changes made to the performers list that allowed clinicians to come and work in general practice who would not normally have worked in this. So this was particularly directed at those people who retired and were able to come back and help out with the COVID vaccination, prospects and stuff, and allow them to work in general practice. They're now continuing and enhancing these flexibilities. And the key one, I think, is number 16, isn't it, Andy? So these changes will permit GP practices and PCNs to employ doctors who are already employed, for example, by an NHS trust, NHS Foundation Trust or health boards, without the requirement for the doctor also to be registered on the medical practitioners list. That is a seismic change to how general practice will run. Potentially, because of the change in flexibilities.
It does, doesn't it? Yeah, you've got F2, fancy doing a locum in practice, a bit with suitable supervision, maybe more competitive with a MRCP GP locum in terms of price. I don't know. Is this now possible? This could have quite big implications for the existing workforce and allow increased flexibility for service providers. It is really interesting.
It is. It does state in number 17, supporting guidance will also be issued to clarify that non-GP doctors should not see undifferentiated patients and that they continue to be required to operate within their sphere of competence. So I think that's important to recognize. I guess, if you wanted to see this in one particular view, you could see this as having, for example, a consultant of elderly medicine doing frailty clinics for your network directly. You could see this pediatrician doctors, whether at various different stages, reg level, consultant level, SAS doctor level. This is basically creating SAS within general practice effectively. But allowing them to work in general practice to see, specific children-based clinics and things. You could run orthopedic clinics to get through the backlog of, you know, your local orthopedic wait list and stuff like that in terms of your specialist clinic, dermatology. There's so many different ways this could be used. I guess the concern many people would have is the supervision element that comes with this. There's no funding for the supervision aspect.
No funding for supervision, and there's probably no funding for those lofty ideas that you've. Those are all great ideas, but I don't see a funding line for it, and I think it's potentially more likely, you know, reducing the cost of delivering service by bringing in people who haven't got MRCGP potentially, or I know that's what a lot of people would fear. But you're right, there are some positive ways that this rule could be used as well.
And I guess looking at it with my trainer's hat on, obviously we are unfortunately seeing a differential amount of people who are not being able to achieve their CCT after training in general practice. This does give them a route to continue working in general practice potentially if they haven't achieved their CCT. Now, whether that's a good or a bad thing overall, I'll be honest, I'm not going to get involved in that debate here. But I think that's a different avenue for those people who have possibly got experience with general practice, but for whatever reason haven't been able to achieve a CCT in general practice. So I think there are considerations in that aspect to make. Like you mentioned, Andy, is this a different way of having a different costing workforce work in general practice? Obviously, there's a lot of angst already around the PA workforce going on. Is this adding another element to that?
I can see there being anxiety around that.
Yeah.
Can I bring a comment on Gandhi? Just
go for it.
Sarah McHale, this is what is meant. This is what is meant as the stepping stone to integration with hospital trusts. And actually, you know, whilst a traditional primary care network, you know, may not find this that useful, actually, if your primary care network and practices are integrated with the hospital trust, as is the case in a few places in the country, this could be really, really helpful in terms of moving staff to be closer to the patients and in the place that makes sense for service delivery, you know, when you can also shift the funding around. So that's a very insightful comment from Sarah, and thank you for that.
Yep. I guess I'm going to bring on a couple of other comments. And Nat makes the comment of, why would you want to spend your money getting the wait lists down for specialist services down? So I guess it comes down to how you approach it. You could absolutely approach both the ICB and the local NHS trust saying that actually, if we do this extra piece of work, what will you give us back for doing so? And hosting this close to the patients, not having to use your estates and being able to see the patients in a different way. I guess the other way of looking at it as well, if you happen to be particularly a considerably large practice or a federated practice, having that specialist knowledge within your structure directly may help better with not only with patient care, but actually in terms of complaints and that kind of stuff, because you've got a specialist service that you can tap into if you have those resources available. So I think, you know, it's not just a monetary aspect and things, but I definitely agree with Dave. Is there a point in having a GP register then with this? It raises the question, what is the point in having a separate GP register if you're going to do this? And maybe that's what we will see. Well, yeah, I guess that's the thing. It puts some of the requirements on general practice to supervise these roles, which is the unwritten aspect that's been commented here, which already general practice, particularly GPs, are doing a lot of that for the ARRS roles as it is. And in many areas, unfunded or not funded anywhere near the level of work that it is, which is why we've seen a reduction in availability of GPs for the past few years up until, you know, the past 3 or 4 months or so. So it all contributes to the chaos that we're feeling. And I think this is going to be an interesting one.
But there potentially is a signal here for GPs or for the profession that we may need to further move to operating, you know, at the top of our license, you know, in supervision of the more numerous other roles, and that could be what a successful GP looks like, you know, rather than holding on to, you know, the bread and butter of seeing undifferentiated patients or lower challenge patients, you know, because in that area, I guess with your MRCP, you're competing with potentially lower staff with a lower cost base. So it's interesting implications for the workforce and people entering the workforce.
So next, I'm going to go to tools, which is the next section from where you are anyway, Andy, which is registering with a GP. So it's number 18 and 19. So this is just a really quick mention. So it's about trying to change the way that patients register with practice. They'll be maximizing the use of the new online routes and suggesting to patients that actually this is a better way to register with your practice. I think many practices have already taken advantage of this as a way for practitioners to register. I know a lot of platforms enhance this further. So there's people like GP Automate, JivJaff, Health Tech One, who enhance this by using robotic process automation to support practices and teams and things and registering their patients. But this and the paper form will continue, but they are looking towards more people using this because they feel it is genuinely time saving for what practices could do. So I think it's a positive thing in my view, but yeah.
Yeah, it feels positive. We use an online registration option as a practice, and it's popular and works well and reduces, work in the back office actually. So it's a sort of net gain for us. It's interesting that these sorts of things are beginning to appear in the contract because this represents sort of using contract variations to standardize and reduce variation in the patient experience of operating at different practices. So it's this is a good thing, but actually these sorts of changes, could be seen as reducing your autonomy as a practice to operate how you want if they continue to introduce these sorts of clauses into the contract.
Okay. Next up, we've got the continuity clause, as I like to call it. So it's a single section, number 20, that Andy's got the highlighted there and stuff. And this is basically bringing continuity into the contract, but there's no detail. Is there, Andy?
No, there's no detail. I mean, I guess the detail must be coming later in the year. I thought it was nice to see a focus on continuity. I mean, continuity, like anything that you're doing additionally, there'll be some expense involved in delivering it, I think. And there's obviously no funding associated with this. So be interested to know whether this just pays lip service to continuity or whether it actually, will deliver something concrete for change for patients. Just made me think of, previous exercises in making sure that every patient over 75 has a named GP, and then that every patient has a named GP, which I think were efforts to try and improve continuity, but I'm not sure that they were really that impactful in most places. So be interested to see what comes, and hopefully it'll be something not too burdensome and also useful, but it's nice to see continuity beginning to be recognized.
Sure. I mean, I'm happy to say that the previous attempts were absolutely pointless, to be honest. They did absolutely nothing. You're being diplomatic. I'm happy to not be diplomatic on that one because I was definitely not a fan of the model that they had before. I think if they were to bring in exactly the same model again, it would be an absolute waste of time. So please, anybody in NHS England, if you're watching this, don't do that again because it was a complete waste of time for everybody. It didn't help with continuity whatsoever. But
it made some good headlines
in the
Telegraph and the Daily Mail, funnily enough.
Which was, again, a complete waste of time and money and didn't help patient care, in my view, overall. However, I think continuity can be achieved. You and I definitely did an interesting webinar live stream just a couple of days ago with Phil from the Foundry PCN, which if you want to watch that, feel free to do so. Alternatively, if you just want to see the relevant part of that, tune in on Thursday, where I've basically chopped out the relevant bits, so taken that down from about an hour and 10 minutes down to 30 minutes in total. So that's what I've been doing this morning.
Because that was the episode about acute access hubs, or same day access hubs. That's what it was about, and that's what Foundry were being held up as an example of, I thought. But when you actually talk to them, it was all continuity based, and it was actually really, really sensible and not really that threatening to traditional general practice models. So I thought that was really interesting. People
and very different to, I guess, what we've heard about the current acute hub models, like the one that we commented on in the end of general practice episode we did a couple of weeks back, where NWL and London-based ICBs are looking at a different type of model and things. But anyway, we're just going to go through the final few changes, and if you do want to ask any comments or questions, please feel free to do so now, because we will come to those once we've finished this. But these are the last few changes that have been mentioned. We've called them the miscellaneous changes just because there's a few things in there and stuff. So Andy mentioned it earlier, vaccination changes in the context of sharing information. I should know this because I'm an IG lead, but I'm curious to know what impact this has from an information governance point of view, whether this can be mandated. Because
I think that probably needs some exploration, I think, because in terms of kind of numbers, anonymized data, a lot of that's already shown and available in dashboards. But I suspect they might be thinking about patient level data, because I saw this as a way of enabling PCN level, ICB level projects to get out and vaccinate children and make a real impact, or at least a precursor to those sorts of projects. But I thought it was interesting, and again, I think it's interesting that I think more and more practice data is being shared with the ICB. We saw that the data around the digital telephony services is going to be shared. And then also the next clause, we'll talk about workforce data collection in a second, but there is a trend towards information which normally would sit within the practice being shared more widely. And I think there's lots of implications for that. Could be positive in many ways, but also could be an information governance risk and could be seen as threatening if this is used for kind of contract management sort of purposes.
Or other organizations, Andy. So the part I didn't like, and any other system nationally required, that doesn't restrict itself to health.
Yeah, it's quite an open,
Yeah.
quite an open statement.
So I must admit that was the part I didn't quite like in the sense that, you know, and again, that's probably why it may be worth going through some of this with the DPO and stuff and things. And interestingly, that's the reason why a lot of practices decided it wasn't in their best interest to give proactive access to records, because it contradicted their individual practice requirements as a data officer, in terms of what they were being mandated to do, because the contract was at odds with information governance law to some people's perspective. So I'd be really keen, and again, I should know this, but I don't know everything when it comes to data governance. I'll happily admit that. But if there is any data governance leads out there, DPOs and stuff, how does this relate to the contract variation versus information governance regulations and guidance? Because actually, the fact that it doesn't specify it's not health-based organizations is a slight concern when you're giving individual patient data, potentially without their consent.
Yeah, needs addressing. Although the overall aim of doing this to improve vaccination levels is laudable. So
absolutely
I think
agree with that. And I think in
the principle behind this and the level of importance it's being given is positive, I think.
And I think in that view, absolutely agree that it's always a positive aim to try and vaccinate our populations better and more effectively, because then you've got the intelligence to know which areas to focus on and stuff. You mentioned the workforce data collection area. I want you to explain this, but I'm going to come in with a comment from the webinar afterwards.
Okay, so it's short, so let's read it. Practice and PCNs will be required to submit workforce information on a quarterly basis to the National Workforce Reporting Service via changes to the GP contract and network contract DES. So we currently submit workforce plans at PCN level, and that allows the system to have good awareness of who is working where and how many people are working where. Now, I think this will be a very new thing for practices, because it's very difficult for the practices to know, for NHS England to know how many doctors are working, how many shifts in each practice. They get access to the ledger now through GP appointment data, which gives them some idea of how many people are working there relative to the population. But this gives them another level of information about the number and types of staff that are working there. And if you're sort of thinking, oh, we have an independent contractor model, you know, we have autonomous independent contractors delivering care, you know, as long as they are meeting their contract requirements, why does NHS England need to know this information? You know, it might be one position. On the other hand, you might say, well, actually, you know, planning and training for the workforce that needs to be there to support the ecosystem of health providers that we have is complicated, and we need data to do that. So I think there's kind of two ways to cut this, really. But I think some people might be, you know, sort of worried or feel that this is, you know, creep of government knowledge of what happens inside our small businesses. I'm really not quite sure where I stand, actually. I think if you're staffing sort of appropriately, I'm not sure that it necessarily matters if the government know, but interesting. Any thoughts yourself, Gandhi?
So one, and this was based off the webinar. So one of the questions obviously came about was the lack of funding to manage particularly the workforce amount that we have. We mentioned earlier about the living wage increase and stuff and how that'll impact reception-based care and costings and stuff. And one of the comments made by Amanda Doyle, and it's not word for word, but effectively, it's really easy to do this in hospitals because everyone's on agenda for change. Obviously, general practice doesn't have agenda for change, and the pay scales that people are paid in general practice are completely different, and they don't have the intelligence or the information to know what that is for general practice, and therefore they can't budget for it, and that's why they can't make compensatory changes to the funding to allow for those pay increases / pay amounts that they have in general practice. I would argue they can. they're going to have workforce data in terms of numbers of people. Now, the answer they may have is that they don't want, practices won't give individual pays for their staff, which I agree with, because you shouldn't be giving individual pay. But Agenda for Change works on banding basis in terms of how people are paid and structures. I don't understand why you can't come with a similar or the same concept in general practice to allow for that information to flow. So you can say that we have 10 members of practice on a, 12 to 15 pound per hour rate. You have, various different levels within that. That would give you the level of intelligence data to allow for that level of workforce planning. That would therefore mean that, quite rightly, general practice can show the information of what it's recruiting with its monies, and actually demystify this whole concept that by giving general practice more money, it just goes into the partners' pockets.
Yeah, interesting. And I guess if you're a high profit practice, you might see this as a way of them being able to sort of have more business intelligence to enable them to set their price more competitively and potentially put pressure on your profitability, I guess. But yeah,
maybe
interesting. And
yeah, an interesting
that's not
concept.
happened before. So
no. So last couple of things that's on there: digital tools for catchment areas. So this is about having both a digital and a physical representation of your practice area. I think
it looks like they'll supply the tool. We have to use it, and actually it may well improve everybody's understanding of where boundaries are, which is probably no bad thing, I guess.
No. And the final one is about armed force veterans. So making sure that there's sensible access and stuff for armed force veterans when offering their services, making onward referrals, because there are separate routes for those options if applicable and things. So
something I always do actually is the Armed Forces Covenant. Certain services will prioritize for armed forces, always with saying if they're a veteran, and sometimes systems can you can code it and it can be identified when you're making referrals. We've got a few veterans on our books.
And then the final one, which I made sure I was not going to forget, is the enhanced services that we haven't talked about, which is the weight management, which is way down at the bottom of the letter.
So simply, thing, isn't it?
Yeah, simply put, it's going to continue at no increase in costs. So £11.50 per referral. Continue to do it out of the 7.2 million pot that they've allocated for this and stuff. Just confirming that it's still continuing, basically, and things. And that is all the changes that they have specified. Now, as Andy mentioned, this seems to be a fait complete by NHS England and Department of Health, etc. and things. I know we're getting some really interesting comments coming through in some of this. So I guess one to answer says, Sakib, can part of the ARRS money be retained for GPs for their supervising role? No, it's reimbursement, simply put.
Well, you've got flexibility to take some of the clinical directors' money now from the core fund. It's in the core funding pot, so you could use that for supervision. Well, sorry, I'm being.
But before you start taking my pay, thank you, Andy. Just important to recognise that was always possible with the funding pots that were existing before. So the leadership and development funding and the core funding could already be used to pay for supervision routes. The key thing is it was never enough, but that's a separate matter. Recent BBC recognition of continuity by Dave McConnell. Absolutely. There's recent papers and repeated papers that keep coming out that show continuity of care is the most distinguishing factor that helps in terms of better outcomes of healthcare in total. And also probably the best way of delivering care is how you do it when you've got a unavailable workforce, basically. Mike Neville, the CD role sounds like the spec is being blurred and the PCN manager and ops roles. Potentially, you could argue there's some element of, that could you, as Andy mentioned, could you water it down a little bit? But don't forget there will still need to be one responsible person who signs off that CAIP funding. So whoever's willing to take that responsibility along with it and things. Steve Taylor, acute hub costs are interesting. Average of £48 for appointment at RE hub, so acute respiratory hub. Given the core cost of general practice is about £20 to £25 for seeing a patient with acute respiratory illness and things. Tim Pierce, sounds like the data captured to train AI and ML models, so information can be used commercially, possibly, maybe. Dave commenting that profit's not a bad thing, can reflect efficiencies and partners picking up a lot. Absolutely. I think every partner across the country will say they work hard and stuff and things. So various different comments coming through on some of that and things. What are your thoughts, Andy, in terms of the new contract?
So no new money in either the PCN DES or the core contract. That's the big headline problem, I think, with it. If you dig below, I think actually they are streamlining some, quite a lot of the reporting around QOF and an IAF and removing and protecting income from some of those points. So I think that leans into this, increased kind of trust approach. We'll give you the money and you deliver with the money, which I think is something we've been asking for a while, and it's something that they're beginning to deliver. So I think we need to kind of acknowledge that is there and that is a positive. I think it's just interesting to see kind of perhaps a slowly increasing role for ICB in determining the release of money, with the 30% of the CAIP funding. I know that was always dependent on the ICB, but I just see an increasing role for the ICB in terms of collecting data and being involved in determining, when things have been achieved. And I think the potential for service grade doctors working in general practice is a big sleeper thing, which I know I'll give you credit for that, Gandhi. You saw that. I didn't see that on first pass. So I think it's disappointing from a funding perspective, but actually some of the other elements are not bad. So actually perhaps the team wants, have not done too bad within the envelope of funding that they've got potentially. But the funding is a massive problem. Go on, Gandhi, what do you think?
I mean, I'd echo a lot of that. I think, as everyone is, that the amount of funding being given to general practice is disappointing. Important to remember, general practice is the only area of the healthcare system that has outperformed over the past, few years since COVID hit. But more importantly, we provide 400 million plus appointments per year at the moment, more than any other part of the sector, and we do so on the least amount of the share of the NHS funding by compensation. I think in terms of the work that general practice does, it feels very much underappreciated by the fact that the Department of Health feel that they want to invest their funds that they're giving to the NHS to other parts of the system rather than general practice. That's the decision and modus operandi they've been operating on for many years and continue to seem to do so, unfortunately. And this whole concept of you've had a 5-year contract, we're not going to adjust it. And now that we can adjust it, we're going to basically give the absolute bare minimum that we feel is appropriate. And yet we're still going to ask you to do loads of stuff. So let's be clear, access will still be a part of this. And the access parts haven't been clarified. It mentions around the continuity of care metric that we don't know and will probably come later on in the year. I suspect that will probably come right before an election. What do you think, Andy? It'll make some really good news stories, won't it, about the fact that, a new government is in.
We'll see some footballing with NHS general practice as we get closer to the election, I think.
Absolutely. And, we saw with modern general practice when it was unleashed upon general practice last year, how it was quite prescriptive in some aspects of how things would work and stuff. So whether that will happen again will be interesting to see. I do agree with you. Some of the reconciliations of the QOF and the IAF are actually quite welcome because they are less bureaucratic than what they were. So they have listened on that part and making it less bureaucratic. And I understand the concept of saying, well, we've got this survey, so we can't do as much as we'd like because we have to wait for the outcomes of that consultation and things. I'd argue that's poorly timed if that was the case, if that was always going to be the case. But fair enough, those things happen sometimes. PCN changes, actually, they don't seem as bad as I think. Probably, I think
more flexibility is good.
The flexibility is very much welcome. I'm disappointed around the way they've built the enhanced nurse role in comparison to what they could have done. And I agree with many other people. I think they could have gone for an enhanced GP role within this, and that would have been separate. But again, I think it's just bureaucracy in my view that they've stuck to that. Very disappointed there's no increase in the PCN funding in terms of the ceiling of roles that you can do. But again, that's the financial envelope. I'm concerned about a couple of those things. So the data sharing from the vaccinations, like I said, I just like clarification on what level that goes to with my IG hat on. And also the performers list changes are open-ended. And raise a significant question around how general practice could function, responsibilities and stuff. And I can see some places doing some really risky stuff based on that. But also, is that what's best for patients? And are they giving what they're saying that they're doing and stuff as a result? So, yeah, I think there's definitely I'd like some further clarifications on bits. I think overall, yeah, it is. This is the problem.
Andy.
It is what it.
There's not enough money there. The quality of service is going to be is going to go
But,
down because there's a less than
but that is given.
inflationary increase.
Okay, so maybe we
That's the
should.
elephant in the room, and it's been imposed without the GPC's approval, our trade union, which I think is,
and that's fair. I think if
good.
if the Department of Health feel that this is the tack they want to take, I think they really need to accept the fact that they are saying to general practice, we're not going to pay you enough to do the work that you need to do. They have to accept there's going to be a change in service to patients, and they have to take ownership and responsibility for that. They can't just say, oh no, well, general practice is doing a crappy job. That's because they're not funding it. Let's be honest on that. They're not funding it to do the work that they're being asked to do.
And it's a big missed opportunity because there's lots of evidence that money spent in primary care saves lots more money downstream. But I guess these are perhaps arguments to continue in the future, and I'm sure they will.
So interestingly, there was a couple of things that was mentioned in the webinar that's not listed in this letter. So if you have stuck around, like the 70 odd people that are still watching us live for this bit.
I'm glad I did. Go on,
yeah. So one thing they did mention, which isn't mentioned in the contract stuff, is premises. So estates and premises, they did mention that there was some cost analysis coming out and changes to the premises costings. I've forgotten the term that they used, but that will be coming out at some point in the, again, near future, and we've seen near future numerous times, but that will address some of the costings. They did accept, so Amanda Doyle did accept it's probably not going to be enough to make any significant changes on a grand scale, but that it would help simplify the process when it comes to estates and solve some of the smaller issues that places are experiencing. That's a big thing because, again, estates and premises is something that's not really been addressed and is a massive problem, we know, in general practice and stuff. So that is possibly something we're going to see in the near future. I guess for all of you that are still joining us, thank you, first of all, for all the comments. So we've seen Sakib saying, thank you for going over this. Mark James, really appreciate your review of the letter and considered views. Joshua, very helpful summary. I guess really important to recognize that this is the NHS England version of the contract letter and stuff. As we mentioned earlier, the GPC are going to do a referendum on this. And I think I would highly recommend everybody involves themselves in that discussion and that analysis and things. And more than likely, we will have more information come through in a few weeks' time, because that's what happens every single year when this comes around. Myself and Andy will definitely be trying to make ourselves available for that. I will point out that's Ramadan for me, so we'll try our best to do that and things when it happens.
Very hungry and tired.
Well, yeah, and stuff. But shortly after that, we've obviously got our PCN Plus conference that me and Andy are going to be doing that with Ben, Tara, and the team in terms of reviewing everything. So absolutely feel free to join that. Unfortunately, the face-to-face tickets are all gone, but you can definitely join us virtually, which is free to do so and stuff. So make sure you sign for that, and I'll put the links to that down below. It's bit.ly/PCN Plus L24, all in capitals. And as ever, we'll be here to help continue to show you all of this stuff. Do check out this episode, which is the one we talked about with Phil Wallach from the Foundry PCN, talking about the changes they've made. And if you do want to watch that watchathon, which is a bit of fun, check out this one right here. And as ever, we'll be here to tech enhance your primary care and learning. And we'll catch you in the next episode.
Yeah, thanks everybody. The comments really make this